Well, good afternoon, everyone. It's great to have you with us. I am Marissa Hassan, Program Coordinator for the South Carolina Coalition for the Care for the Seriously Ill, and we affectionately call ourselves CSI. We do a deep dive into all things serious illness care and the continuum policy and advocacy. We've been in existence since 2010, and one of the things that we have um, really focused on is really looking at post as well as and really working with post with our Department of Health and Environmental Control. And we were able to get post statewide adoption in 2019. We also have done some work around grassroots advanced care planning. And of course, we do a lot of training with clinicians around how to have advanced care planning conversations. We are currently working on the palliative scorecard. And so we've got a group of health systems and providers, hospices, palliative care organizations working on what are ways that we can increase at a state perspective our palliative core ranking so that when the next report comes out by CAPCI at the end of 2027, our ranking would have improved. This month also is Healthcare Decisions Month. We have the declaration that was put out by Governor McMaster. And I know, knowing most of you, that you've been doing things not only in communities, but also with your employees around healthcare decisions. I absolutely love when I can have an opportunity to get out into community and really talk about the benefits of having conversations sooner as opposed to when we wait and there's a medical crisis and individuals are in the ER and they're having to make pressure decisions. And so I want to encourage you to continue to do that work. People are very receptive as we are bringing that information to them. And so thank you for that as well. I apologize that the phone's going off. My husband and I are both working from home today, so his phone is going off. So I apologize if you hear that extra noise going on in the background. On yesterday, we had Dr. Christina McDaniel with us, really talking about integrated palliative care. And man, what a wonderful time we had, just sort of looking at the ways that we can effectively embed palliative care with cancer care. Our theme, as you know, this week is collaborating to transform cancer care. And so every day this week, we're doing a deep dive into the ways that we look at not only for adults, but this year, really also looking at pediatric care. I want to turn this over to my friend and colleague who is going to run the rest of the day, Tracy Fasolino, who is a distinguished healthcare policy fellow. She also is a Cambia scholar. She's a professor at Clemson. I don't hold it against her that she is a professor at Clemson because I'm a Gamecock fan through and through. But despite our differences in the universities in South Carolina, we are absolutely great friends. And she was also so instrumental, along with a few of our other planning committee members, in helping us put together this week. Lauren King, as well as Kari Bradford, Laurie Libran as well. And so we're thrilled to have Tracy lead today's session. So Tracy, take it away.
Thank you, Marisette, and I won't hold it against you either. I would say that we are in for a real treat today in this session. We have an amazing set of panelists that are going to share with us. The focus today is actually pediatric and adult oncology, and really thinking about what that looks like in the clinical space and how we are caring for them. And we have some well-known national folks on this panel today, some people who are doing such great work and have an opportunity to share. I will actually be monitoring the chat. So if you are not able to unmute and ask a question, but there's a really burning question that you want to pose, feel free to put it in there. We will definitely weave that in. We don't have to wait till the very end of the session. I think this is one of those places where you guys have worked before and you've been on these calls. This is really to be a very kind of a relaxed environment, more so that we have time to talk about these things and ask the the questions that we might not be able to ask or not have access to an amazing set of panelists like we do today. So I just want to make sure that you feel, empowered to ask your questions or hop on and share something even that might kind of dovetail with what our panelists are talking about. So the first part here is just to give us a chance for each one of the panelists to share a little bit about their work, their background, where, like what things keep them up at night, why they're so passionate in their space. And then we'll actually turn more to like a Q&A that'll be a bit more organic, but basically driving some of those questions that I know our team on CSI and even us as clinicians have thought about, but we've never had such a great opportunity with an amazing set of panels to be able to ask these questions. So I think that cues it up really well. We have Janice Withicum, and then we'll follow that by Natalie and Michelle, and then we'll close up with yet another Michelle before we roll into the Q&A session. But so I'm going to turn the mic over to Janice to take us kind of through her background, and we'll just go one at a time. And thank you all for coming today too. I'm really excited to hear what this amazing set of panelists have to tell and how to share what they're sharing with us.
Well, thank you, Tracy. I appreciate that introduction. And I'm so excited to be here today and to share with all of you just a snapshot of some of the things I've been working on in my career related to symptom science research. So I think most of you, if I'm looking at the chat right, are involved in pediatric oncology in some aspects. So you already know this information. And I promise this is the most boring slide of the whole presentation. But just for a grounding baseline, making sure we're all on the same page, I will share with you that we have an excellent cure rate overall in pediatric oncology. And we like to talk about that because it's better than the adult world. Our diagnoses are different. We don't see breast cancer and prostate cancer and lung cancer, but we do see primarily leukemia and then the brain and CNS tumors. Most of our survivors, however, do go on to have lifelong chronic health conditions, so 60 to 90% based on what research study you read. We also know that there's one cooperative group, the Children's Oncology Group, that is tasked with carrying out most of the clinical trials that happen in the pediatric oncology and adolescent population. And that's where most of my research has been grounded and where I started. And the other thing I wanted to share is that we do see symptom reports of 2 to 5 symptoms co-occurring at any one time during treatment in all of our patients. So it is important to monitor symptoms. And for those that work in clinical trials, you'll recognize this book and be very familiar with it. So this is the common terminology criteria for adverse events Bible, some call it, but it contains 790 plus symptoms that we are tasked and mandated by the federal government to report for those that are enrolled on clinical trials. What you may not know, though, is that about a third of the items in this book are actually subjective in nature. And that means items like sleep, fatigue, pain. These are all things that are best reported by the patients themselves, even if they're children. And so from our work, we know that clinicians tend to underreport the severity of symptoms compared to children. And parents are often used as proxies, and they're great, but parents tend to, you guessed it, over-report the child's symptom burden. And so the child's report is truly the best mechanism for capturing how they're doing during therapy. So I've worked on several studies over the course of my career. Dr. Pam Hines was my mentor, and she's the one that got me involved in the palliative care research and also in looking at symptom science. And we worked to develop an instrument, a validated survey instrument that would quickly allow children to self-report how they're doing throughout therapy. And I do advocate for collecting symptom reports through these validated instruments. I'll give you an example. As I was doing a symptom assessment one day, we think we're pretty good, and we walk into a room and we say, "How are you doing?" And the kids normally give us these one-word responses, right? Good, better, awful, but we don't get a lot of detail. And so it's important that we really delve in and ask more. And using these validated surveys do help us do that. So one day I walked in, did my normal, "How are you doing?" And the child said, "Great." And the mom said, while you're here doing the survey with them, I'm going to go get lunch. So she walked out of the room. I hand the child the survey pad. He's filling out a survey. And I noticed that they rated their pain level as being very high. And I said, can we talk about this? Because you said you were doing great when I asked earlier. And they said, yeah, but my mom was in the room. And they didn't want to say how bad they were feeling, how their pain was not being managed well, because they didn't want their parent to worry. And so we need to keep in mind that children will protect their parents. And so sometimes using a validated instrument in a written format is a great way for them to report without feeling like they're harming a parent or making them worry. We also know through the course of our research that 90% of ill children that have symptoms do not report them unless they are directly asked by a clinician about that exact symptom. So again, we have to be very, very detailed if we want, to get the true symptom experience from them. This is important because only when we know about the symptoms can we actually work to provide the appropriate interventions. So through our work with Dr. Hines and others, we've worked to develop the pediatric patient-reported common adverse outcome symptom library. It's a mouthful, I know, but it's affectionately called the PEDS PROCTCAE symptom library. It's posted on the NIH website and it's pediatric and adolescent versions. There's even a proxy version, but it's just one instrument out of many that can be used to collect this type of symptom data. If you've worked in oncology in any amount of time, you'll know that fatigue is the #1 symptom that's reported in both children and adults that are going through cancer therapy. So this is described as just a bone-weary symptom. We also know that there are very few effective interventions for treating fatigue except for physical activity. And this is the evidence-based intervention that we recommend. We say walking is the best form of physical activity for those going through cancer therapy, and it is almost always better adherence when a parent, a caregiver, or even a sibling will help the child and participate with them. So most children going through cancer therapy on average get about 6,000 steps a day. I have seen reports by physical activity monitors as low as 700 steps a day. Now that's pretty much getting up, walking to the bathroom and going back to bed a couple times a day. It's not much at all. The normal for an adolescent is 10,000 steps a day. That's the recommended level of physical activity, and children have higher levels. They're supposed to be getting up to 15,000. So you can see our pediatric patients that are going through cancer treatment are very much not in compliance with that. And so when I was thinking through how do I develop an intervention that's going to be motivational for these families and these kids, how do I get them interested in doing physical activity and making sure that they will, agree to do the study? And as I'm thinking through how to develop this intervention, I was a volunteer at the time. It was a Camp Chemo. It was a summer camp program. It's in the Midlands for those that are in that area. And now I think it's Camp Cole is where it's migrated to. But I was attending this as a volunteer, and I noticed there were children with cancer. There were also their siblings, and I couldn't tell them apart. When I was looking at their physical activity levels, they were actively engaging in the same types of physical activity. And I went, aha, there is my intervention. Maybe a camp setting is where I should be focusing my research so that I can get good measures of changes in physical activity. And so that's what I did. I've done multiple camp studies now, but this is data from one of my studies. Quickly, you can see that on average this was a week-long camp, the children were on active treatment. You can see that they were getting up to 18,000 steps a day on average, much higher than their baseline scores, which I shared with you was about 6,000 steps a day. So a statistically significant change in physical activity. You will also note that males had higher steps than females during the course of the camp. That has been consistently true throughout all of my studies. I guess girls just don't want to get sweaty and have their hair messed up. I don't know. But anyway, it is just a consistent finding. Males are more active at camp. You'll also notice that the moderate activity was up to about an hour a day, which is well over the recommended dose for children. And the takeaway point from all of this is that there were no adverse events that were reported when the children were this active, even getting physical, active chemotherapy. So they, in fact, reported just the opposite. They had less fatigue, they had less anxiety, they had less depression, and I could go on and on. It was just great. So then we delved further and we looked at actual changes with physical activity, which are the green dots, and the relationship to self-reported fatigue, which are the red dots. And you'll see this beautiful inverse correlation. So the scale is the higher the number and the dot, then the more present that activity or symptom was. So you'll see that the children that were more physically active had lower reports of fatigue. And this has been, again, consistent throughout all of my studies. And you may say, well, that was just a camp effect. Does it happen in children that don't go to camp? And the answer is yes. We've done it in inpatient settings, we've done it in outpatient settings, we've done it in camp settings. There's this beautiful inverse correlation. Then I wanted to know, but why? I'm the best 2-year-old, but why is there an inverse correlation? What is it about fatigue and physical activity? And so to get at that answer, we started looking at just the underlying biological correlates, looking at metabolite associations. And in that same study, we had collected urine samples for children at baseline and then also at the end of camp, looking at metabolite changes. And associated with mobility are the ones on the left, tyrosine, tryptophan, etc. The ones on the right were associated with fatigue, but also with mobility in several of my studies. And then the ones that are bolded here, the metabolites that are bolded, have consistently shown up in all of my studies, even across different samples. So I have done this in blood, I've done it in urine, and now I've validated, or we're looking to validate, we're in the final stages of doing a saliva-based assay to test for these metabolites and their associations with physical activity and fatigue. So what are the one thing that all of those identified metabolites have in common? And by this picture, you may guess it, they are all associated with our gut microbiome. So it seems like there's something about moderate physical activity that actually activates expression of those observed metabolites. So if I go back, you'll see that or you may remember from chemistry or biology classes somewhere down the line, that tyrosine and tryptophan and indole-3 lactic acid, these are all interrelated and they all are connected to sleep and also the neuropsychosocial pathways. So they are associated with symptoms like anxiety and depression and fatigue. So there is that interconnectivity. So I think that we're just now beginning to tease out the why of why physical activity is so important to address symptoms such as fatigue and others. So that's just a brief overview of some of my research that I've done and why I'm so excited about this area. I do want to give you a few takeaways for you to remember. Number one is to encourage children to do whatever they enjoy doing. Like this little guy in the picture seems to enjoy fishing. So, encourage them. If they enjoy the activity, they're more likely to stay engaged and to be compliant with doing it. Also, you'll see the child's wearing a Fitbit, which is the physical activity monitor. A lot of your patients will be wearing these type of devices or even the Oura rings on their fingers. If you see them wearing them, please ask about it. Tell me about your physical activity. What numbers did you have for the week or for the day even? And then record that so that you can have some record of what their activity level is like over the course of their therapy or even into survivorship. The other thing I would highly suggest is that you help them to set good family physical activity goals. Give them actual step counts if they're wearing monitors. Well, you're at 6,000 this week. Let's see if we can go to 7,000 next week. If you're unclear of how to do that or uncomfortable setting those type of goals, then reach out to our wonderful physical therapy experts and our colleagues. They are exceptional in helping us to set goals for families in this nature. Lastly, I'd like for you to encourage camp attendance. So when your family say, there's a summer camp coming up, should I go? Should I send my child? Absolutely, yes. Please do encourage that. It's good for the child, as I've shown you. It's also good for the parent. I haven't gone into a lot of that research, but our own moderator today, Dr. Fasolino, has, and there's ample evidence that it is excellent for the family as well. So I'm going to end with that. I'm going to give you my contact information here. If you have any questions about anything I've shared, please do reach out. Thank you.
Thank you, Janice. I have a chat already posted an amazing question. This is exactly what I think we were all thinking about a little bit. The Whether they're helicopter parents or not helicopter parents, we all seem to get worried. Is this okay for a child that's undergoing cancer treatment or even, I mean, the whole, yeah, the whole gamut of that. How do you manage that? Because we know parents get incredibly fearful, right? They're going through so much anyway.
Yeah. Yeah. So I think, I always point back to the research because that's what I do. But I just say, look, it's proven there is great benefits from camps. And I also encourage families that are a little bit anxious at first. There are family camps and then there are camps just for kids. Maybe they would be more comfortable attending a family camp where they could go together and they could see how well their child does, and yet they're there to provide some support and feedback to the practitioners. The camps, though, the medically needy camps, or those that provide services for those that have medical needs, usually have clinicians on staff and healthcare providers on staff to help to address some of those concerns that parents may have. Their child's going to be closely monitored and observed, and um, again, they'll come back from camp and they'll want to go again and again and again. So, highly encourage it.
Thank you, Janice. And I'll share with the group here. Janice has taught me so much about summer camps when she works at Clemson with me, and she didn't. So we're against you, Marisette. We're 2-on-1 now. But we actually had an opportunity to work together on a rapid review. I just put the link to it in the chat box because I think when you're considering, framing the conversation about summer camps, and to Janice's point, we always like to lean into what the data says and to help support families. So that was a rapid review that a team here at Clemson did, and that's where I learned a lot from Janice about the role of summer camps in symptom management. So, you think about me being on the symptom side management for palliative as a clinician, but then being able to work with her and learn so much more about the family camps, the role of camps. There's camps that are 2 days, there's camps that are overnight, there's camps that are day camps, and just the amazing benefit from it all. I echo what she says. She's been in it way longer. She's nationally known for the work that she's done, but I was very happy that she was willing to share with someone who is a strong clinician in palliative care and thinking about what are the benefits of summer camps. And now I know when I was a kid, I loved going to camp, right? That was great. So I think that just tag on. That link takes you to the abstract. If there's any reason that you would want the full article, do let us know, and we'll be happy to get that directed to you. So, Janice, did you have anything to follow up on that?
No,
Nope.
it was great study, very fun.
It was a lot of fun. Yes. So thank you so much. I'm going to turn the mic over to another one of my very dear friends and peers, Dr. Natalie McAndrews, and I'm going to let you take it from there.
Thank you so much, Dr. Fasolino. It is a pleasure to be here. I don't have any slides, but I'm gonna sort of give the arc of my research and how I really started to focus on families as a family-focused researcher. And a lot of what I feel drives my passion and what I want to do from a research perspective, and inevitably, translating that into practice, comes from my days working as an intensive care nurse and later as a clinical nurse specialist. When I started out as a brand new nurse, I thought, well, where am I going to get the best opportunity to work with the sickest of the sick to really hone my skills? And while I went into the experience thinking that's what I was doing, that's really where I found my passion and my joy in working with families and engaging them in care. This has grounded my thinking as a researcher from here on out. It was so important to really be with people in such a difficult situation. So much of what we do is really about supporting patients and their families. And I always think back to those experiences when I'm trying to think about where are we going with family engagement. The other component of my clinical practice that informs my research today is the work that I did as a clinical nurse specialist. I ran family meetings with my colleagues, but I was the orchestrator of them, really recognizing as an expert clinician when we were missing having them, bringing families and teams together to have those meetings. I was really trying to fill a lot of the gaps in communication and family support and learned a lot from that perspective too. And I always think back to one day, and I think everybody can relate to this. It took me all day just to organize a family meeting for a very complicated patient. And, that makes it very hard to be able to give families the care that they need when just that one thing was so hard to do. The other early element of my work really surrounds moral distress of healthcare professionals. And I, of course, as a nurse, experienced a lot of moral distress in my work in the ICU, but I also recognized how that can really affect our care of patients and their families. Family care gaps can be driven by our inability to care for families as we want within rigid systems. And so when I went back for my PhD, my dissertation work was really looking at how ethical conflict affects our ability to care for families. So it was a dissertation. It was not probably the very best science of all time, but that's part of our learning, right? That trajectory. But I did find that there was a relationship between family-centered care and depersonalization, an element of burnout. And the more depersonalization we have, the less likely we're going to be able to deliver family-centered care. So, as I moved on from my dissertation work, I centered into family engagement. Where are the barriers? What are the facilitators? And where do we need to go with that to do that work well? And that actually brought me to a lot of lifespan and pediatric work. As a clinician, that was not my area of practice, but I have found all the pediatric researchers over the course of my career and worked very closely with them. And what I found and what our teams have found is that there's family factors, there's healthcare professional factors, and there's a lot of organizational system factors that influence the quality of family engaged care in cancer care. And the other thing that I think is most interesting is that yes, developmentally, there are differences between children's and adults, but across the lifespan, and even from a global perspective, we have more similarities in those challenges than differences. So, as I've progressed in my career, I've also recognized that families, when facing serious illness, need to make sense of that experience. And that took me into the realm of existential distress and cancer care is basically where I made that part of the pivot. And a population of great interest to me when I was working in the ICU, many times because there was a lot of ethical conflict surrounding these cases, was the stem cell transplant population. So, after doing some exploratory work with that population of family caregivers' ICU experiences within that context, I started to look at potential interventions for those caregivers. And I found something called meaning-centered psychotherapy, which is a palliative informed supportive care intervention. And what's interesting about this intervention is it's primarily been studied in an advanced cancer context. So I reached out to Dr. Allison Applebaum, who did the caregiver adaptation of meaning-centered psychotherapy, and started working with her to understand what would it be like if we were to offer this to stem cell transplant caregivers early on in the treatment trajectory. And so we did a little pilot to take a look at that. And we certainly saw outcomes change in the right direction. This was a small pilot study of 32 caregivers, but their qualitative feedback was so meaningful. And I think as we look at many different illness contexts, this particular stem cell transplant being a very often curative or sustaining life, these supportive care elements, the palliative care elements, are often missed and people feel very unsupported. So that was a big part of why I wanted to look at that intervention with this population. But then as I did some more work with patients, I recognized that they are also facing a lot of existential distress. And even when things go well, there's always the fear that, something will change in the future where the transplant could fail. I might have a different kind of cancer in the future, things like that, fear of cancer reoccurrence. And that also lent itself to putting on my family-focused lens and wondering, could we do this for dyads, which is where I'm focusing a lot of my work right now. And I think dyadic work is really hard, but it's really needed, particularly in cancer care. And I did make a shift in my career where I was in Wisconsin. Now I'm at Mayo Clinic in Minnesota. And in the past, I've really only been able to work with adult populations unless I, develop a relationship with the standing alone children's hospital. But at Mayo Clinic, I do have the opportunity to support pediatric care. So I'm very interested in looking at how an intervention like meaning-centered psychotherapy could be used to help support parents. In a lot of my conversations, as I started at the organization, our parents are not getting enough support. And that made me think, we're as caregivers across the lifespan, more similarities than differences. So that's something else that I am keen on looking at, trying to put some pilot grants in to look at that as well. And I think my ultimate goal in the work that I'm doing is trying to get family support programs in place and evaluating their impact on patient, family, and healthcare outcomes. We do all this beautiful work, we do all this research, but that implementation science piece, getting it into the practice, understanding how do we pay for it, how do we create a workforce that can fill this need because there's so much going on in healthcare. I think the other thing that I think a lot about in my work with families is just how important it is for them to be able to walk beside each other. And so we know there's value in peer support, but how is that integrated into family caregiver programs as well? And our team has a beautiful opportunity. Allison Applebaum and Nick Dion Odom have an R25 grant where they're helping cancer centers integrate caregiver programs across their health systems. So we're on a learning journey with that, and I'm very excited to understand more about that. At our Mayo Clinic Arizona location, we do have a peer support caregiver program. So we're trying to see if we are to implement that across the enterprise, how could that look? What else do we need to do? What other information do we need to make that successful? So that's a little bit about my research trajectory, where my passions lie. And I'm really excited about the dialogue today, and I'll hand it back to Dr. Fasolino.
Thank you, Natalie. And for those of you that heard her talk about her nurse-led meaning-centered psychotherapy for cancer caregiving, I popped the link in to the abstract because I think that is a great place for us to kind of think about family caregivers, and it's certainly one of the most, like one of the most growing fields. We haven't really studied and been present with some of that, so I appreciate that work. Thank you. Natalie, I appreciate that. So now I'm going to hand the mic over to Michelle. We are super excited to have her, having joined South Carolina. Woohoo! I believe I'll let her take the tagline off of that. Thanks, Michelle.
Thank you so much. It's great to be here, and I'm really excited to be with you all. And having recently joined MUSC in Charleston, I'm just thrilled to be with you in this event. My name is Michelle Malika, and I am a faculty member in the College of Nursing at MUSC. I am also at the Hollings Cancer Center. I'm Director of Survivorship Care Delivery. I'm going to sort of shift us a little bit and look a bit more across the lifespan, but focused on cancer survivorship. And I will just start by saying that I focus on cancer survivorship because of my time as an oncology nurse. So, very similar to the other esteemed speakers, I was able to see sort of gaps in care for people that made it through treatment and often ring a bell at the end of treatment and then are sort of faced with life after cancer. And I quickly realized that cancer survivorship runs the gamut and is much more than just surveillance for recurrence. So I'm hoping to sort of talk you through the components of cancer survivorship and what we have learned. Previously to my role at MUSC, I was in the Office of Cancer Survivorship at the National Cancer Institute, which is part of the National Institutes of Health. I was fortunate to be the deputy director, so I sort of have that 50,000-foot view, but also now being at MUSC, helping them grow their survivorship program and having a new opportunity here. So today I'm just going to briefly talk about backgrounds and definitions of survivorship and survivorship care. I'll talk to you about the components of survivorship care and some considerations of specific populations across that lifespan and what we have at MUSC and across the state. I'll start just with some definitions. So we recognize a cancer survivor as any person from the time of diagnosis through the balance of life. So this is a broad definition. It includes people that are on treatment, that are off treatment, that are living with advanced or metastatic disease, or that were treated with curative intent for earlier stage disease. Most people think of a cancer survivor as post-treatment, or some used to think of it as 5 years after treatment when you are sort of in remission. But this is a broad definition that really arose from survivor advocates themselves and caregivers. This term may not resonate for all people with a history of cancer, so that's important to know. It's more meant to capture a population for the purpose of research, clinical care, and policy. Collectively across the United States, we have over 18 million cancer survivors, so people after a cancer diagnosis, and many are living more than 5 years after their diagnosis. We have lots of trends in cancer survivorship. We've talked a bit about the pediatric oncology space, but there is also an aging of the survivor population that was deemed the silver tsunami. So that's those purple bands and the blue bands where you can see that exponential growth in older adult cancer survivors as people live longer and are more long-term survivors. When we talk about cancer survivorship, we're really referring to sort of the experience of being someone with a history of cancer or a caregiver of someone with a history of cancer. So that is a state of being. So that includes all of these different experiences, symptoms, needs, and challenges that are experienced by people impacted by cancer. And again, survivorship looks different based on the stage of cancer and the cancer type and the disease trajectory. So this is a figure that we developed at NCI to really illustrate this point, where the people on the left-hand side are those who are diagnosed with early stage cancer, who are treated generally with curative intent. And in the middle is a growing population of people who are diagnosed with advanced or metastatic cancer or who progress to metastatic cancer, who are living for a very long time. They often receive treatment with the intent to prolong their life, but they have real survivorship needs. And then again, the group on the right are those who are diagnosed with or progress to terminal or end stage cancer, where we're really looking at end of life care. When we talk about survivorship care, we are talking about care that can run parallel to active treatment. It is intended to address or mitigate the impact of cancer in its treatment. So we're not talking about treatment, cancer-directed treatment or therapies, but all of these components that you see on this figure, including managing physical and psychological effects, monitoring for recurrence in new cancers, promoting healthy behaviors, all the way to assessing genetic risk. This all falls under the umbrella of survivorship care. So really, we're looking at a comprehensive approach that is not necessarily limited to one single visit or one single document. It's really a care approach over time. And survivorship care is incredibly important. It has been shown to improve quality of life for people who receive it. It enhances health outcomes and promotes healthy behaviors like physical activity and nutrition, tobacco cessation, and importantly, it supports caregivers, as we just heard in the last talk. I do want to clarify that a related concept or care model is palliative care, and Dr. McDaniel did such a nice job yesterday presenting that comprehensive view. And so I don't need to tell this group or the audience about the goal of palliative care, but I will just say that palliative care can be delivered at any stage of cancer, and it also is very, very related to cancer survivorship. So, survivorship and palliative care, as you see in this paper, led by Dr. Laura Petrillo, both focus on several similar aspects of care, including symptom management, often decision making, and patient-centered goals. But I would just say, rather than trying to say this type of care is survivorship and this type of care is palliative care, I think we need to emphasize the collaboration of patient-centered or family-centered care as we're thinking about these two concepts. When we talk about models of care, that is referring to the type of care that's delivered to different types of patients and by different types of providers. So our goal here is really to deliver tailored survivorship care, the right care to the right place at the right time and the right patient. With the right team. There's lots of different models of survivorship care. The one that you see on the top is oncology led, where an oncology team will lead the central aspects to survivorship care. This is a highly resourced model and pretty common nationally. I will say it's not necessary for all cancer survivors. It's also not sustainable given an overburdened oncology workforce. Primary care led is again where primary care leads the aspects of survivorship care. This is often for people who are treated with earlier stage disease and don't have as many symptoms or long-lasting late effects. Multidisciplinary survivorship clinics are often for higher risk cancer survivors where multiple types of providers will see patients often in a single clinic visit or the same location. Again, these are also require high resources, and so often only for those that have higher risk for things like recurrence or secondary malignancies or symptoms. And then shared care is often the preferred model, although it's challenging to implement. This is where oncology and primary care partner in different aspects that they do well for survivorship care. It really has been recommended as the gold standard for most survivorship patients, although no one size really fits all. I just wanted to give a very brief overview of the types of effects that we focus on in cancer survivorship. First, people after a cancer diagnosis and their treatment experience physical effects, and those include acute, which may be occurring during treatment, long-term, which last long after their treatment ends, and then late effects are those that occur several months or years after their cancer treatment, and that includes things like cardiovascular, cardiotoxicities, subsequent malignancies, or issues with fertility. And it really is the provider's role to assess for symptoms and burden and provide recommendations and referrals. Psychosocial effects are incredibly common, as we've heard already, in cancer survivors or people after a cancer diagnosis. And that includes things like anxiety, depression, fear of recurrence, or fear of progression for people living with advanced and metastatic cancer. Financial hardship is a huge issue in people after a cancer diagnosis as well. And then I spoke a bit about monitoring for recurrence, but surveillance regimens really vary based on cancer type and risk and include things like follow-up visits, imaging, and labs. I will say that often providers get hung up on the recurrence part, which is obviously central to most cancer survivors and their anxieties, but it is not the only part of cancer survivorship. And then screening for subsequent cancer. So having a cancer diagnosis in many cases does lead to higher risk of other cancers. And that is due to genetic factors or lifestyle behaviors. Often past treatments can lead to higher risk for subsequent cancers. And so screening and follow-up are essential to enhance early detection of disease. Health promotion is essential for cancer survivors during and after treatment. Things like stress management, physical activity, sun safety, tobacco cessation. It's really important to assess lifestyle behaviors, even if someone is smoking during treatment or after a cancer diagnosis, to educate them on the important impact of quitting even after a cancer diagnosis to support long-term wellness. We've talked a bit about primary care-led models, but primary care providers are essential survivorship team members. They often support key components of cancer survivorship care, including screening for subsequent cancers, health promotion, and chronic disease management. So it's really important to coordinate that care, and that can be challenging. Happy to discuss that later, but survivors need guidance on when to contact oncology versus primary care. And then finally, communication and decision making is essential to make sure that survivorship care meets their goals of care and the needs of the survivor and the caregiver. You heard a lot about advanced care planning in the palliative care talk with Dr. McDaniel yesterday, but it's essential along the continuum, no matter where they are at in survivorship. I just wanted to very briefly highlight specific survivor populations. You've already heard about childhood cancer survivors who were diagnosed under 18 years of age, but they have a high risk for long-term and late effects. And so often survivorship care will emphasize that increased risk for subsequent cancers or for those symptoms, and transitioning from pediatric to adult care is really important in this population. Adolescent and young adult survivors are those who are 15 to 39 years of age. So they often have a huge toll on their emotional well-being at a time when they are managing career changes, employment, financial concerns. They may have challenges adhering to follow-up care because of their life stage or moving or their demands. And then older adult survivors are often managing their cancer along with other comorbidities. So that impacts polypharmacy, their treatment tolerance, their symptoms, their independence, and their quality of life. And I can't emphasize enough, but we already heard about this, that cancer caregivers are essential members of that care team, even in long-term survivorship. So often we support caregivers during treatment, but it falls off. As people move into longer term survivorship, it's important to assess for burnout, to support caregiver health because it is directly related to survivor health. And at MUSC and across the state of South Carolina, we offer several survivorship services for people, and you don't need to be treated have been treated at Hollings Cancer Center to receive these services. We have supportive care services, including social work, genetic counseling, occupational therapy, physical therapy, psychosocial oncology. We also have a strong onco-primary care program where we have a primary care physician who will see patients within our cancer center and attends to survivorship care needs. We have virtual support groups for patients, and we have survivorship clinics and caregiver support groups. And you can get more information here, and I know this is, the website is here, but also happy to follow up after. And then I just wanted to close by offering a few resources for survivors and caregivers. And then my next slide is about providers. There are several American Cancer Society, the National Cancer Institute, and others have lots of resources for cancer survivors and their caregivers. And then finally, for providers, the Association of Cancer Care Centers has survivorship resources, the Commission on Cancer, the NCI, and the Oncology Nursing Society. And I'm looking forward to the discussion. I will just close and provide my contact information. Happy to follow up. Thanks.
Thank you, Michelle. And I also, because I seem to have a little kind of rhythm going here, I just shared a link to a paper that you have published that talks about the portfolio analysis update of the National Institute of Health Funded Grants, looking at survivorship research. For those of you who are really interested in some of what does it look like from a funding perspective, I hope that's okay. But I thought,
Of course. Thank
looks
you.
like a great paper to kind of tag for later review. So thank you for sharing. And we are really, really fortunate to have a child life specialist on this panel. So I'm going to just transition the mic over to her, but I think that the work that she's doing is amazing, and the clinical background that she's going to share with us. I don't always get an opportunity to actually talk to a child life specialist, so I'm pretty psyched to be able to introduce Michelle. Thank you, Michelle, for joining us.
Thank you. I'm going to try to share my slides, which I got out of. But just to start, I have been at MUSC for over 30 years. All right, sorry, just looking at my slides.
Take your time. Take your time.
So yes, I've been here for a long time. The slides will be more entertaining than me talking. So anyway, our department has changed a lot, but our role has basically stayed the same. I mean, it obviously evolves and grows with time. But when I started, I was the 4th child life specialist here. And now we have close to 20. So we've definitely grown. Sorry, can you all see the slides? I'm not sure what's showing. I'm not
quite yet.
Best at this. Let's see. Okay, sorry about that. So anyway, what I'm going to talk about today is some of the things that I've done with patients, and I think I want to start by saying how important the relationship is that we build, and that's how we're able to do the best work. Building trust, building rapport. Patients need to trust you to listen to you and know that you're saying what you mean. Sorry, I really want to show you these slides. All right, let me had them up too long before.
Oh, just go ahead and take a second. It's not a problem. I think we're all really excited to hear from you too.
Yeah, the slides are great. So
I know we've seen them already, a brief glimpse out at the beginning. And if there's a way for maybe one of our health science team to step into to open them up for you, we can certainly drive them as you present.
yeah, so before they were showing, and now let me just look a minute. I think it's my view, maybe.
Keep talking, Michelle. I'm going to work on getting them for you, okay?
Okay.
Because I do have them, so I'm going to work on getting them to share. Okay.
See a screen now, Michelle.
Oh, okay. That's good.
Yep.
You see your desktop screen.
Okay.
Isn't technology just such a pain sometimes?
So I see it, but I just don't know how to.
Yep, we're seeing it.
Oh, good. Thank you.
Way to rock that, right? Love it. Thank you for being
Technology
so
is,
persistent and diligent. That just shows what folks like us are able to do.
well, technology is not my thing, and we're lucky. I'll just jump way ahead that we have a gaming technology specialist even on our team now. Has been here almost a year or maybe a year. Anyway, so our department has grown and changed, but our psychosocial care, I think, has remained the same. So at MUSC, child life has always been well integrated into the care team. My first person that I was working with, our director, Sandra Eberman, started child life like in 1985. And then there were started with herself and a few others, and I was the fourth person on our team, and I'm still here. I think I'm still the only one that's been here that long. So I definitely have the lengthy career award. So anyway, we've always been well integrated and worked with the team to provide the best psychosocial care for our patients. And we see patients from 0 to actually 25 or so now. A lot of patients in their early 20s are here for osteosarcoma and other Ewings, things like that. So it's not just young pediatric patients. And I know from everything everyone's shared already, one of the groups that I've been interested in wanting to help out with is the AYA group, the adolescent and young adults. And I think there's obviously been a lot done. Michelle, you talked about it earlier. But I think one of the patients I worked with when I was early in my career, Amanda Dykes, her mother, Linda Plunkett, is also trying to start an AYA program here and help fund it. And I think that's exciting. So, and we still keep in touch from way back when Amanda died in like 1997. So it's been a long time. So one of the things I do is help children feel more comfortable in the hospital and not fear so much, because especially when you're a child, the hospital can be very scary. You've got all kinds of strangers looking at you, talking to you, touching you, and it causes a lot of fear. So one of our primary goals is to help them feel comfortable, help them feel like a child still, and help them learn about what's going on so they're not so fearful. And in this slide, I have, let's see, a 5-year-old who loved medical play and acting out all the things that had been done to her on a doll. And through watching that, we can kind of understand what misconceptions children have. One time a child was with a teaching doll and started giving shots in the eyes and shots all over the head, and just said, there's no stopping what people are going to do to me and all the shots they're going to give me. And then, so obviously they don't really understand what's going on, and it's our job to help them realize that this is the part of the body that's sick, and this is what we're going to work on. This is what doctors are going to help, not just everything and anytime. So kids definitely need space, and they definitely need to understand what's going on. With teenagers, they lose peer contact, which is so important to them. Providing things that they like to do as well. We had a shoe decorating, not party, but the Citadel basketball team wanted our kids to decorate their shoes. They had a game to raise money for pediatric oncology. And so some of the teenagers really got into that, and then watched the game later and saw the shoes that they decorated that the coaches were wearing. So that was kind of exciting. So again, when I started, we were in the old hospital, and I think now we're in Sean Jenkins. It's beautiful. It's definitely helped me from becoming burned out, staying here so long and being in our other hospital with adult patients, and it just needed a lot of love. So now moving into this new hospital, it's beautiful. Patients and families love it. And ever since we've moved here, which was 6 years ago, right before COVID, our department has started growing. So I think our oncology department has definitely grown in this hospital, but for child life to grow with that, it's really nice. When I started, I covered an oncology unit and the PICU, and you realize with the intense cases that you see and everything going on, it's not really, you can't do your best work when you are spread so thin. Then I moved on to working with patients in the clinic and other inpatients. And it wasn't just oncology, it was hematology oncology, and then solid organ transplant patients. So again, going back and forth, different buildings, trying to help all the kids is just impossible when you're one person and you have so many kids. I can't even remember how many then. Now it's even more. But now, luckily, we have an outpatient child life specialist as well as myself who covers inpatient. And we see quite a few kids. Our clinic even sees up to 40 a day and growing. So just to talk a little bit about what Child Life does with patients, we have different modalities and interventions, including therapeutic play and expressive arts, preparation and education for all the things that are going on that the child may or may not want to know about. We take the child's lead when we're providing education to see, do they want to know? Is it too scary to know right now? One of the things about oncology and cancer treatment is that it's not a short-term thing. It will last years. So my goal is not to immediately tell the child what is going to happen. Like, oh, you've been diagnosed with this. This is going to happen. You're going to lose your hair. You're going to get all this medicine. You're going to go home, but then you're going to come back. We do it slowly because that would overwhelm anyone. So teaching children about it and families and parents, you have to take their lead. Sorry. You have to take their lead. And I've even seen teenagers who I'll be ready to show them a port on a doll or another teaching method. And I've had some teenagers say, I don't want to see it right now. I'll maybe look later, but I'm not ready. And that we have to respect that. And I think part of my job as child life specialists, we definitely assess the patient's needs first. They hear a lot that they don't want to hear. And I tell them, well, you can tell me how fast or how slow you want to go with this. And they may have already seen it and heard it from the doctors coming in, because usually they hear a lot, even at all ages, even if they're 6, 7, 8, and they're hearing all kinds of things. There's not always a space and time to go take them away from the families and talk with the families first and then talk with the children, which is what would be ideal, but that can't always happen. So understanding that and understanding that they've probably heard way more than they should or that they need to, we try to respect the teaching and the helping them cope and all that just by following their lead. So again, finding ways to help children cope, it's all individualized. It's based on the child's interests and kind of go from there. And if they just want to draw and color for the first couple days, that's fine. We try to make them comfortable, try not to have them exposed to too many things that are going to scare them. We do have playrooms in all of our, on all the units, on all the levels. And on oncology, we're lucky we have an inpatient playroom where I am right now, we have a bone marrow transplant playroom. We have a clinic playroom. So we have 3 on our floor. And if you've ever been to Sean Jenkins, you've seen it's beautiful, but the only playrooms that have views from the windows are the oncology ones. So we have beautiful views. The kids love coming in here. It's, a chance to get out of your room. We also have a large atrium and a beautiful garden outside on the 7th floor, which we encourage patients and families to use. The issue with all the oncology patients coming up here is they get chemotherapy, their counts drop, and it's best not for them to be exposed to too many people. So they do learn to wear masks at quite a young age, but we usually encourage them to stay on level 10 where we are, and they're not exposed to as many other patients. The other part of that, though, is the doctors and all the team encourage them to go outside and get fresh air when they can. And at least we kind of learned this from COVID. When we opened, we had to shut everything down right away because of nobody being sure what anyone could do or who could be exposed to who and all that kind of stuff. So we still had outside and masks, and that was great. The playrooms are wonderful also. And what I try to do up here is offer a variety of activities, toys, materials, from all ages. Kids are interested in playing. Even adults want to play. So we have things to kind of match everyone's needs. Up in the corner, we have a 22-year-old who loved her Cricut and was trying to teach me how to use it. And she donated one to us and just was great at all the expressive activities. And she said that expressive activities are healing. And I think that was a perfect quote. On the right, we have a 5-year-old who was enjoying being out in the garden and painting and doing all the other kinds of expressive activities and sensory activities, because when kids are in the hospital, everything has to be clean. No germs. Try to keep everything as clean as possible, and children are at some point afraid to get messy. So one of the favorite things to do is making slime, finger painting, things that we can kind of control and make sure it's not too messy. No digging in the dirt and no planting flowers right now. The little girl on the underneath here, she made worry dolls. And that was one of the expressive activities I introduced to her. And she took it and ran with it. And she started making little dolls and gave them names. One was Nick, Nightmare Nick. He was one of her nurses at night. And so their worries, like one was for shots, but she started bringing all her caregivers into it, the nurses, and displaying it in these figures. And it gave her a way to talk about things that were going on and not complaining, but just saying at night, sometimes I have nightmares and Nick is there. So it was just interesting to hear kids, how they express themselves, how they share their stories when they're comfortable and trust you. And that's what we do. We listen and follow their lead. Just over on the right and down here, we have a family, a mom and her 2 sons coming to visit and donate presents after they lost she lost her youngest son, and they lost their brother. He was up here for about a year, and again during COVID when everything was very difficult. But one of the things he liked to do every day, his mom would come find me and I'd go in his room and we'd play a little soccer in the room. And that's what he wanted to do. And the parents could have done it. The family played with them all the time, but it was their preference and his that he had time to do something with someone else outside of the family, outside of the medical staff. So that was what I was able to offer him. Not just soccer, we went on to do many more things, but this leads me to the part about end of life care and what we do for children when parents and children often know before we tell them that the chemotherapy and treatment is not working. We had one family just recently come in, and what they wanted was to stay here because it had been normalized for them. They had been here for 6 months. Decided not to go home on home health care, hospice care, Hands of Hope, which I'll show a slide about in a minute. So they could have, but they also lived 2 hours away. They were used to being here. Their child who ended up passing away this week was 3. She's almost 4. She was diagnosed at 2. And they spent more time here in the last couple of years than they had at home. So they also had a daughter who was 8. And so the 2 children loved playing here. It became like their home. They played with the nursing staff. They would just everyone was friends with them. Everyone knew them. And to them, staying here was a lot more comforting than going home. They also lived 2 hours away and knew they'd have to come back for transfusions and didn't want their child to be in pain. So some of the things that we offer, definitely we go by the parents' desire, what they want. And what they wanted was just to keep everything normal. So playing was in her routine, and she loved to come in the kitchen and play with cooking and just other activities. And her sister also was just very active, and they really felt comfortable here. So a lot of people think you definitely want to go home as soon as you can, but this family did not. So again, respecting families' wishes. So she had a routine. She came and played every day and did PT, OT, all the other things. We have a great Next machine, which I don't have a picture of, but it's a gaming system. If you're not sure, which I wasn't, that you just use your movement and motion to activate it. So you can do basketball, you can do Fruit Ninja, you can do dancing. And that's a great way for kids to get out of the room, move around, have fun. So all the kids on our unit love that. Back to the legacy making, which is one of the things we do if a family desires that. And I have to say, most often families do go home. So it's pretty rare that they stay. But when they do stay, we have palliative care as well help us, but we will do whatever the family wants to do. This little girl I was just talking about did not like getting her hands messy. So she said, yeah, I'll use a paintbrush to paint. I don't want to use my hands. So no kinds of handprints or anything were done when she was awake and aware of what was going on. But Beads of Courage is one of the things that I start when patients first come in. And if you haven't heard of it, it's a great program. Every bead has a meaning. So for example, yellow beads are inpatient stays, white beads are chemotherapy, black bead is a poke. So going back a second, it's hard to keep up with all that. There's a menu that parents fill out and they get the beads from me. And there are also a lot of different symbolic beads. So when parents are in this with their kids every day and they have 1,000 things going on a day, it's hard to keep up with everything that's going on. So one of the good things about it, there's a charm that says 100 bead. And so almost for everything that she had done, she had 100. So I put together beads for her, and I have a wonderful volunteer who's an artist and does mosaic art and has an office and everything, and that's her passion. But she's going to she comes here every Monday and helps kids do mosaics, but she's going to put together all of Anna's beads and make a nice large mural out of it. Something that some kids do like to string them and parents like to string them, but that is a lot of work. And if you do it from the beginning and keep up with it, it's a great way to tell your story. And all, like kids who are 2, later on when they're 10, they have their beads of courage and they can talk about their story and all the things that the beads stand for. And it helps them to kind of symbolically show it and have something to show, which talking about chemo and pokes and surgery is not very attractive. So at least you have some nice beads to show for it. And that's just one small, it's a great journey that they can keep up with beads if they choose. So sometimes we do handprints and footprints and whatever families want. And again, our palliative care team is great. And we have a coral cart of all kinds of things families can choose from to do, from fingerprints to necklaces to photographs and other things. So jumping around here, sorry. I did talk about families choosing to stay here or going home, and most often they do go home. And we have Hands of Hope. It's not through MUSC, but it's their own program, which is great. And they have child life specialists on their team, and definitely at end of life and more critical stages of Hands of Hope going into the home, child life specialists will go and help children at home, the siblings, the patients, and everyone else. Again, following family's lead and seeing what the patients need and offering support. They also have opportunities to, I guess, grants. They can have like a child, we have Make-A-Wish and all those things, but usually at the very end, they have something else they can offer too. So they are a great resource. Back to our department and some of the things we do. Family-centered care is so important. And I know I touched on that, but without the parents and siblings here, this one patient, Anna, would not have, and the family would not have been together. And that's not what they wished. So Ava, her sister, stayed for a really long time. Almost, she was here every day, visiting her sister, and together they remained as a family. And it was, I think, what they wanted. They got to do some trips to the aquarium. They would go to church. They would go visit their home every once in a while. And I have permission to share their story. Just
Hey, this is Lyle Jack, the social work care manager with Prisma Health. Hope you're doing all right. I was just calling.
Sorry, not sure what that was. So anyway, again, some of the things that we offer are teaching through medical play. We have teaching dolls. We have ways for children to, it's easier for children to see things and touch and feel. We have Aflac ducks that are donated that are great. We can show them the port. The Aflac ducks have emojis so they can hold them up to the duck. And we talk about feelings because they have all the feelings cards that go with them. And then there's a relaxation card that plays music. And I know even one 20-year-old that was here, his mom said that was his favorite thing. Sometimes we don't offer ducks to the young adults, but if they want them, we do. And he loved his. He brought it with him to every admission. He would play the music when he felt stressed. And it was just great to see. It's also good for siblings. They can see how their sister or brother has a port and what that means. And again, just talking to patients who are children, also anybody really, it's people like to see things and they like to have hands-on and see what it feels like. Kids like to actually access a port. So in a doll, if they want to do that, I give them the opportunity so they can be the nurse on the other side instead of being the patient. And we go through what kinds of feelings the patient might have. Do they cry? It's important for them to hold still. It's okay to cry, but let's see how we can make it better. We can put on the EMLA cream. So all the things we try to assess pain management and keep up with that. And our nurses are great here. And the doctors, everybody wants everything to be as pain-free as possible for children, also adults. But since I work with children, I can speak to them. They like to have control. They like to be able to tell you what they want. And if they aren't sure what they want, we have play sessions and we do medical play and find out what the child might be thinking that maybe don't have the words for to express. So there are many ways to get the families involved. And again, through play and activities that they enjoy. Our atrium in the hospital, they can visit when their counts are good, and kids love to do that. The garden is wonderful for families and siblings to visit, so they don't always have to be in a patient room. And again, when we opened during COVID, it was a very hard time, but the garden was where most people would end up. And we didn't used to have an outdoor space, so we're very excited to have that now. And it's well utilized. There's also a quiet area with swings, and it overlooks the James Island Bridge and the sunset. And the helicopter pad is right over it. So I was sitting out there with a patient one time, and the helicopter took off from there, and that was kind of exciting. And that patient ended up telling me that she had been brought in on the helicopter and that she actually loved it. I was thinking maybe she was scared. She said she loved the ride. Her parents couldn't go with her, but the people on the helicopter were so nice, she said, and she thought that was very exciting. So I could go on and tell stories, and I have so many stories that are wonderful with patients, but I'm sure people might have questions for some of the people who've talked today.
Thank you, Michelle. That was
Yes.
truly amazing. I do apologize for the slide thing, but you rallied and just did a great job. It's wonderful to kind of think through how all of these presentations intersect with each other. I am going to keep track of time. We have about 9 minutes, and I want to just open the mic real quick. While you're thinking, we do have a question in the chat for you, Michelle. Janice populated one for us, and I think it's a really good question. She says, and Janice, if you want to mute and ask your question yourself, you're definitely welcome to do that, and I will mute myself.
That's fine. Michelle, thank you for that presentation. I just had a quick question because normally, I've had parents in the past say, well, my child's playing just fine, so they must not be having any pain or other symptoms. And how do you help parents understand that sometimes play is different in children?
Great question. Great point. Probably just the role modeling. The child comes in and plays, or in the room, wherever they are, and allowing the parent to see that this is great. It's healthy for the child to obviously move around and get their mind off of all the things that they may think about when they're in their bed, and the nurses and doctors come in. When they're playing, they don't think of that. And our play areas are safe spaces where a doctor can come in and talk to them, but they can't do any kind of procedures or anything that would interrupt everyone around. But anyway, parents see that they play and that they're happy, and just talking to them about it. We also, when you talked about Camp Happy Days is a great camp that most of our kids attend. And the parents see what a great time they have. They got to meet so many friends. They come back energized and feeling better. Kids are much more resilient than adults, and they want to play, even if that might hurt a little. They would rather get up and play and have fun and not focus on what's going on in their body and what's going on around them. So parents see that, and then they understand. This is great. And I often hear like maybe a child's been in bed for a week, and if they're just diagnosed, I'll take in the Aflac duck, which happened recently. And the little girl started laughing, and her parents were like, I haven't seen her laugh in a week, and this is so great. So it's just a child's response and their expression of feeling much better when they play that helps the parents understand. We'll do whatever we can to help them do this, even when we go home.
That's awesome. Thank you, James, for asking that question too. I think when people ask questions, it's like we're all thinking about this, and it's good when someone kind of takes the lead. And I see Jill's ask a question. I think this would be directed to you, Natalie. Would love to hear more about meaning-centered psychotherapy, perhaps a case example. And I think like what Michelle just said, you could talk about this all day long because you have all these examples, but it sounds like Jill's real interested, and so am I. It's a kind of a new concept. So if you don't mind giving us a quick case sample, that would be great.
I would love it. Thank you for that opportunity. So meaning-centered psychotherapy, it's a seven, if you're doing it individual, it's a 7 session intervention. Typically you do 1 session a week, but many times in studies we'll give them up to 2 weeks because obviously when you're seriously ill, like things are coming up. It can also be done in a group format. So we have definitely have the evidence to support that it's probably more efficacious when delivered in a group, which is probably that peer support element that's added to the intervention. When we do the intervention in a group format, it's 8 sessions as opposed to 7. But the intervention is really quite lovely. We teach people about 4 different sources of meaning that they can use in their lives. And I don't have time to go into great detail about all of those, but like looking at, their past, how that informs who they are today, who they want to be, and the legacy they want to leave behind. So that's our historical source of meaning. The attitudinal source of meaning is how you face life's challenges and the strength that you can gain from that. Creative source of meaning is about how you put yourself into the world, right? Career, family, volunteerism, all those kinds of things. And then my favorite is the experiential source of meaning, which is really just connecting to other people, something greater than yourself. If you have that's something where the client goes, where they want to really think about some of those spiritual and religiosity kind of questions as well. But a lot of times we just talk about things like, connecting with nature, love, beauty, humor, things of that nature. But it's a lot of, this kind of reminds me a lot of qualitative interviewing. You're just meeting that person where they're at and exploring things from the vantage point of, where they're trying to go, but also trying to teach them how they can sort of reframe. I don't want to say, it's finding meaning in spite of suffering, right? There's a lot of suffering that happens in cancer, but we can still find a way to connect with what's important to us and stay connected to who we are. So that was a very wild and winding explanation, but I just love the intervention. It's quite beautiful, and it hasn't really been well studied as nurse led. I did I was the interventionist, spoiler alert. So that was the pilot that I did. I was able to deliver the intervention, which was really important because I needed to understand it better. And then I'm not sure if I think the publication is out. Allison Applebaum did nurse delivered meaning-centered psychotherapy to outpatient. No, they were homebound, I believe, homebound patients in the oncology context. So yeah, so it's great and would love to. I think the pediatric space is ripe for delivering this intervention. So I'd love to see how like delivering it maybe earlier on in the pediatric trajectory could be helpful for parents.
Absolutely. Thank you, Natalie, for giving us a really quick high overview. I'm looking at the time. We have about 2 minutes left. So we have come to the end of an amazing panel discussion, listening to what some leaders are doing across the field. If possible, those of you on the panelists, if you don't mind popping in your contact information, so that the other folks that have further questions would probably love to follow up and ask you some more information. And I see Jessica has wonderfully put in the link to the evaluation for today's panelists. And I think that's going to be real easy. Just click on that. It's a red cap. So you guys are probably familiar with those working in your space. Thank you so much to this great panelist. So give them a big round of applause. They are phenomenal doing such amazing work across the country and probably even more international that we didn't hear about. But I think these are evidence of why we get up and we continue to fight the fight or battle the battle or win the win, right? All the way across. And it's such an impressive panelist group. So thank you for taking the time. For those that you were able to attend, I know it's crazy busy as a clinician, but I think we thank you very much for joining us. Come back tomorrow. We're going to have another great, exciting a session for South Carolina CSI, making great pathways and building great networks. So thank you all. Have a wonderfully blessed day, and we'll see you next time.